everyone, it's a great pleasure to have the possibility to present results from the Eurofinger project with focus on precision prevention for dementia in Alzheimer's disease. The main mission of Eurofinger, which is a consortium funded by the GPND, is to develop, test and validate methodology and tools to support precision prevention for Alzheimer's disease and dementia. We use multi-domain approaches, which use pharmacological and non-pharmacological intervention to reduce the risk and prevent Alzheimer's disease and dementia. And our work gathers 7 countries with 11 partners. 3 of those joined during the consortium activities. And all of these partners bring many data from 5 prevention trials and 7 observational cohorts with decades of experience in the field of dementia risk reduction and prevention. The Eurofinger consortium builds on the pivotal FINGER clinical trial, which for the first time tested a multi-domain approach in older adults at risk of dementia to benefit condition. As you can see in the scheme, the main intervention in FINGER included a multi-domain approach with nutritional guidance, physical activity, cognitive training and social stimulation, and vascular care optimization. This multi-domain approach was compared to regular healthcare advice. The intervention lasted 2 years, but we have periodical follow-up of the study population to see the long-term adherence to lifestyle improvement and benefit on cognition. After 2 years, we saw that the FINGER had several positive results: cognitive benefit, lower risk of cardiovascular event or disability, lower risk of multimorbidity, improved health quality of life, and economical benefit, really showing the potential for public health strategies based on this type of model. So Eurofinger aimed to further optimize and grow the FINGER model to enable further studies of similar nature. We wanted to develop new tools to clearly measure the prevention potential of individuals. What are the characteristics that make people more likely to benefit from specific intervention? We also wanted to develop protocol to test pharmacological and non-pharmacological intervention for dementia risk reduction. We are developing online registry to bring the knowledge and information on preventative activities to the community, so citizens can search and find easily information and join preventative initiatives and studies. And finally, we also need guidelines for clinicians on how to best approach patients that are in the at-risk spectrum and need guidance on how to communicate the need to assess the risk, the results of such risk assessment, and take jointly with the person decision about the way forward. All of these aims were done with the contribution of public involvement in the consortium and also taking into account that we needed to implement a response to the COVID-19 pandemic. A quick overview of some of the main results of the Eurofinger project. We did further analysis in the FINGER trial to understand what is the minimum amount of adherence to the multi-domain intervention that needs to be achieved to really benefit in terms of cognitive improvement. And as you can see from the graph here, from the dark line, an adherence of at least 50% of the activity proposed in FINGER was needed to achieve significant cognitive improvement. So the lesson learned here is that we need to implement strategies to support adherence if we really want to achieve clinically significant cognitive improvement. We also assess long-term in the FINGER trial participants the risk of cardiovascular events, which could be underlying worsening of cognitive function. What we saw that after 2 years and extended follow-up, people in the active group had a reduced occurrence of cardiovascular and cerebrovascular event. And this risk was reduced by 50% in people that had already experienced a cardiovascular event, as you can see in the graph by the red line, really showing the additional beneficial effect on this type of approach, not just cognition, but also cardiovascular health. Additionally, within the consortium, we have a feasibility trial called MIND-AD that was from a previous GPND-founded project and aimed to test for the first time the finger model in people with already cognitive problems due to the presence of Alzheimer pathology. So people with the diagnosis of prodromal Alzheimer disease and presence of modifiable risk factor for dementia. This is a feasibility study that lasted 6 months plus 6 months open extension. 93 people were recruited from 3 different countries, and the overall retention rate was over 90%, showing that this type of approach is feasible also in people that start to have cognitive problems due to Alzheimer pathology. As you can see, there was a high adherence to the different components of the intervention, and this adherence was associated to improve risk score of healthy lifestyle, the ATISH score, and to reduce the risk of score of vascular health. This is the FINRI score, showing that this type of approach can be extended across the at-risk spectrum of Alzheimer's dementia. Another important aspect was to develop a protocol to combine for the first time lifestyle plus medication. Now, in MIND-AD, we tested medical food, Suvenade, that was previously shown to have beneficial effect in people with prodromal Alzheimer disease. The Netherlands launched within Eurofingers the Finger NL efficacy trial, where the finger model is tested together with Suvenade to really improve cognition. And then we also developed another model where for the first time we're testing a drug, metformin, together with the finger lifestyle-based intervention. The MedFinger trial, it's soon to start, will include 600 people from 3 different countries and will last for 2 years. Finally, I want to mention the role of the public involvement. The advisory board provided a very meaningful contribution despite they needed to adjust to a digital environment because in-person meetings were not possible during the pandemic. And among the improvement that they help us to achieve in our research activities, I want to list the improvement in the terminology that we use in prevention research, what are the motivation and the barriers to really engage and ensure adherence in trials combining pharmacological and non-pharmacological intervention. And finally, what are the expectations when creating online registry for improving brain health. We also had to deal with the COVID pandemic, and in this, we participated in the Worldwide Finger SARS-CoV survey. Worldwide Finger is a bigger initiative inside which Eurofinger is a main chapter. The SARS-CoV survey was done under the Neurology and COVID-19 Global Forum run by the WHO. We did the survey in 5 countries, try to measure what are the direct and indirect effects on the pandemic on factors relevant for brain health. And we indeed found detrimental changes to lifestyle, such as physical activity that was reduced, increased consumption of unhealthy food, increased problems related to mental and psychological well-being. We also noticed a huge increase in the use of digital tools that can offer opportunity to develop preventative intervention through digital platforms that can be sustained also during new waves of the pandemic and expanded in geographically isolated country. Finally, just to mention the Eurofinger, it's a main chapter within the larger network, Worldwide Finger, of trials focused on dementia risk reduction and prevention. And so we are driving innovation in this field by developing new methodology. I want to thank you for your attention. These are all the country institutions. I also want to thank you, the advisory